The fact that if it's a USC, what I usually say to the patient is that if you don't hear anything within the next 2 weeks, please let us know because we're going to chase it. Then the examiner knows that you know this is important and you've got a plan in place and safety net as well. So the reason I put in these webinars that's been going on for the last few months is that because there are some misconceptions and there are questions that I receive from registrars. The objective of this evening is to help you with these common questions. Not too long ago, I started the RCA back in 2020, so I understand the ins and outs of the RCA and I can understand the pain that you're going through because it's very difficult to actually record for RCA because there are things that you can't control depending on which practices you're working and the pressure. But there are things that you can do, and this session, I'm hoping that you're going to take some key insights that's going to help you in your preparation because I really believe that there's an opportunity for you to actually get the best of what this exam is. And so hopefully you'll get some insights, and at the end there will be a Q&A, so if you have any questions, then I'll be happy to answer them. The objective of this evening is to help you to get more recording because a lot of registrars ask about this question, how do I get more recording? And I'm going to give you 2 methods to help you to get more recordings. The second objective is to help you to calibrate your cases. If you're not benchmarking your cases, maybe you're not sure which cases that you need to submit because you don't know whether it's challenging enough, then we will talk about what are the things that you need to look at and what are the domains to look at, guide you in calibrating your cases. And then the third objective of this evening is to look at the case selection to help you to plan ahead so that you have the best case selection when you're submitting for the RCA. Because each case that you actually put in your selection of cases has 18 marks. So it can actually make all the difference between a pass and a fail. So having a great selection of cases is really important, and that's something you need to plan ahead. If you don't remember anything from this evening, then I'd like you to make sure that you remember this slide, at least this slide, because this is very, very important. If you think about the reason for the RCA, what is it? What is the purpose of the RCA? The purpose of the RCA is to help the examiners so that they can see whether a GP registrar is safe and fit for independent practice. That's the ultimate reason why you've been asked to actually go through this process of getting the RCA done. So we need to make sure that you can demonstrate your capabilities to practice safely and you're fit for independent practice. That's something that will start your thinking from an examiner's perspective to think about what examiners are looking at. So why do candidates struggle? There are various reasons why candidates struggle. The first thing is not getting suitable cases. This is something that's quite frustrating, and a lot of registrars aren't sure how to get more suitable cases. And if you're not getting suitable cases, then even if you're very good at consulting, you won't be able to demonstrate that capability that you've got because you don't have evidence. So that's why it's very important to make sure that you're doing what you can to get suitable cases. So how do you do that? With the constraints of working in your practice and having all these other things going on, it's very difficult. You have the workload pressure and you're having to go through volume of patients and the other things about training that you have to go through, and also the pressure of the seeing patients and chasing results, doing home visits. So it's very difficult to actually think about taking an exam on top of that. And also the other constraint that GP registrars commonly encounter is that the team are not fully on board. If the practice has got its own struggle, then they might not be able to help you as much if you don't actually ask for it. And then the last thing is the clinic setup is not optimized for recording. Depending on how your clinic is set up, it will affect the number of patients you're getting and how suitable are these cases. So the workload pressure is something that is very difficult to manage as a registrar if you're in a busy practice and you're having to actually do your RCA. But there are things that you can do. So we're going to focus on what are the things that you can do to pass this exam. Think about who can help you. It's very important to actually think about the team that you've got, because the RCA is a team effort. When you are sitting the RCA, everybody in your practice needs to know that you are sitting the RCA, from the receptionist to the care navigator, all the clinicians, the GPs and the nurses and the practice manager. Everybody needs to know that you're going to sit the RCA. And it's very important that you let them know what the RCA is about, because if they don't know what the RCA is, then they're unlikely to help you because they don't know how to help you. So the receptionist needs to be somebody who's your best friend, who you're talking and you're telling them what exactly that you're looking for. Tell them about the RCA, what sort of cases you're looking for, and also let them know what are the cases that's not suitable for RCA. For example, tell them that when you're doing the recording, cases such as follow-up, medication review, or fit note requests, these won't be suitable for the RCA. So ask them to avoid booking these cases in your clinic, because otherwise you're going to get these unsuitable cases for RCA. And also let them know what are the cases that are good for RCA, because chances are the receptionist has been working in that practice. They know who are the patients who can actually suit within a 12-minute consultation, and they will be able to help you if you let them know how to help you. So I would recommend that you get a list of suitable cases that you're looking for and print the list and hand it to your receptionist. Let them know what sort of cases that you're looking for. For example, if you want to get some more cases about child problem, so ask them to book child problem on your list. So your care navigator is also a key person in the RCA. If in your practice there's a person who's actually a care navigator, they will be receiving all the inbound requests. So then they filter through these inbound requests, and if they know what you're looking for, and if you ask them and you actually tell them exactly what the cases that would be suitable, then they can book these cases in your clinic. The clinicians are also seeing their own patient and consulting. So if they have interesting cases, then they could also book on your clinic list. And your educational supervisor, who plays a key role in the RCA, because your educational supervisor is going to verify your cases and make sure that the consent is taken appropriately. So these people will be able to help you and the other GPs in the practice. So make sure that you actually speak with the team and inform them what exactly the RCA is about and what they can do to help you. If you don't ask for the help, then they won't be able to help you. And then, last but not least, you can help yourself. You can do a lot to make sure that you're getting more suitable cases, because this is your exam, and if you don't take responsibility for this exam, then nobody else will take. So compared to the CSA, the RCA is where you have to do more work, because you actually have to think about getting the cases to be able to show evidence that you're safe to practice as an independent GP. So there are things that you can do to take advantage of the fact that there's an open book test, and you can actually select your cases, and you can see whether if your case is not great, then the examiner don't need to review it because you don't submit it. So that is something that you didn't have with the CSA. The first method is to approach the team members, explain to them, ask for cases, educate the team member, give them example of suitable cases and unsuitable cases, because if they don't really get it, what is it that you're looking for, then they're unlikely to help you because they don't know how to help you. And then you also need to make sure that you're reminding your team that you're taking the RCA very frequently, because otherwise they're going to forget, or there's millions of other things that they need to go through, and you're probably not going to be on top of the priority. So that's why it's important to update your team. Let them know, this week I've managed to get a pediatric case, and if this is a team member who's actually booked that patient on your list, then make sure that you thank that team member, because that would encourage the team member to help you again. That will reinforce the behavior. So if somebody's actually booked a really interesting case that you've managed to record and it's suitable, then thank them and let them know that that was a good case. And on the other side, if you're finding that you're still getting follow-up cases, you're getting medication review, then you also need to bring that on, because if you don't bring that up, then the team member won't know what is happening. They would think that everything is going fine. So that's why it's important to keep a feedback loop and communicate frequently with your team member. If there's something that's not working, then let them know, and then you can actually see how you tweak things so that you're getting more recordings. Because if you don't do that, then you'll find that you're not getting cases and you're not doing anything about it. So if you're doing something about it, engaging with your team and letting them know and reminding them, they will be more likely to help you. Another tip I'll give you is that if you can ask your rota coordinator or the person who actually booked the clinic to put on top of your clinic recording for RCA, that would be a prompt for the people who are looking at the clinic list to see that you're doing the recording. And if there's any patients who they think are suitable, they can actually book that patient on your list. So make sure that you ask for help and remind your team member and engage with them, and keep a feedback loop so that they know when there are good cases and which cases to send. If, for example, you've already had a lot of pediatric and now you want to focus on mental health, so you need to let them know so that they don't keep giving you pediatric cases. Does that make sense so far? So the second method is, it's very important. If you've tried the first method and it's not working for you, then it's very important to have a discussion with your educational supervisor. This discussion will really help you if you found that the team is not being helpful in terms of giving you the cases that you need for the RCA. Then you need to have a discussion about your clinic setup. If your clinic setup is not right and it's not working, then seek permission from your educational supervisor to actually book your own cases so that you can actually cherry pick on your list which are the cases that would be suitable, and then you book these cases. If you have more control on your clinic, then you'll be able to book yourself, and that will give you more chances of getting suitable cases, because you probably know the cases that will be suitable rather than somebody who's not sitting the RCA. So having this discussion with your ES is very important. You might find that it can be intimidating if you're asking something like that, but this is something that you actually need to ask, because otherwise, if you don't ask for it, it's unlikely that your educational supervisor would think that's necessary. You might say to your educational supervisor, you've tried the first method and it's not been working very well, and you'd like to try this method and see whether you can get more cases. So you can start with a trial. For example, ask them whether you'd be able to actually try this in one clinic a week. So if you're coming to your educational supervisor with a problem, it's very important to propose a solution. Don't just come with a problem, because they're unlikely to help you. You need to make it very easy for your educational supervisor to help you. So propose something and see whether that's reasonable, and then your educational supervisor is likely to agree with you that we could try that because you're struggling to get more cases. And if you find that this is working, then you could ask for 2 clinics or 3 clinics in a week where you can book your own patients, and that will help you to get more cases. So now the next challenge that registrars are facing is that they don't know how to calibrate the cases. They don't know whether a case is a low challenge or medium or high challenge. So it's very difficult because it's not always black and white which case is high challenge, which case is low challenge. A case could be high challenge to a registrar who's not got any experience of obstetric and gynecology, but a registrar who's actually working obstetric and gynecology may have a very good experience and may not find a case challenging, for example, a case of menopause. So it's not always black and white, but there are things that you can look at to help you distinguish between whether a case is considered to be low challenge or high challenge. So how do you actually establish that? So first thing first, I'd like to say that there are reports that the college has published, and they clearly say which are the cases which are likely to score low mark. Cases that you want to avoid are medication requests, simple pill review, pill check that a nurse could easily do, Follow-up cases are not good because you're not doing much of data gathering, because the data gathering has already been done by somebody else, and it's unlikely that you'll get new information. You're just repeating what's already on the notes of the patient. Recurrent problem is also not a very good one because it's tend to be low challenge. It's already been diagnosed and patient keeps coming back for the same treatment. Discussion of results is also one of the low challenge cases because it's likely that there has already been a history taken, possibly an examination, and then it's just discussion of the result. So sick note as well is not worth doing because it's low challenge. So these other cases are unlikely to score well. So avoid these cases. How do you establish whether a case is high challenge or low challenge will depend on 4 different domains. The first one is a diagnosis. So the diagnosis will tell you about the level of clinical challenge. The management will also be one of the factors that you need to look at, because if you're having to work hard in the management, then it becomes more challenging. But if not, you're not working very hard in the management, then it's low challenge. The next 2 domains will tell you a little bit about the complexity of the case. So it depends on the patient. Some patients are more complex than others. Maybe a patient has multiple morbidity. Maybe a patient has like unexpected, unrealistic expectation, or they may have worries. So the patient as well will actually add a layer of complexity to a case. And the 4th factor is the situation. The social circumstances and the situation will add another layer of complexity. So to help you get an understanding of this, I'd like to invite you on a quiz. I'd ask you actually to think about the first one, the diagnosis. Think about these presentations: anxiety, chest pain, tennis elbow, menopause, diabetes mellitus. Which one do you think is the high challenge one and which one is a low challenge one? If you had to rank these from A to E, which one would you put as the highest challenge to the lowest one? Now, it's very difficult to say which one is more challenging than the other because, as we talk about, it will depend on the person. Someone might find chest pain very challenging, whereas somebody else might find menopause more challenging. So the diagnosis on its own will not tell you whether a case is very challenging, and it is not something that we have. It will really depend on the clinician. So for example, anxiety could be low challenge if it's a mild anxiety and you're not having to do much about it, whereas chest pain could be very challenging because you're having to rule out life-threatening problem, and there is more of a process of distinguishing whether this is cardiac, whether this is respiratory, or whether this is gastro. So each of these presentation would have its level of challenge.
Hello, hi, thank you very much. My name is Dr MRCGP RCA. I've got just a basic question about the passing criteria, basically. Is it just the number of marks that we need to have to pass the RCA, or is it the number of consultations as well? So one this question, and just another one, that if we fail a mandatory, one of the cases that we submitted for a mandatory case, does that mean we fail the exam, or is it okay to just fail the mandatory case?
So that's a very good question. So the way you pass the RCA is based on the overall mark, and you don't have to actually pass each case to pass. So if you fail one case, and if you fail a mandatory case, criteria case, and you're still getting an overall score above or equal to the pass mark, you would still pass the RCA. So you don't have to actually pass X number of cases to pass the RCA. Does that make sense?
Yes, thank you. That really helps.
Great. USC referral in itself, I wouldn't say it's a low challenge, because if you're having a patient very anxious and you don't expect this, then you're almost having to break this bad news that you're referring them to make sure they don't have cancer. And if you're having to do more work in that, to discuss about what's going to happen. They're very anxious, and you're managing this anxiety, and you're actually telling them exactly what's going to happen in the management. Then you're doing quite a lot of work in that. So that could be a good submission. There are other domains that you need to look at. For example, the situation of the patient, and also whether they'd like to actually discuss this with their relative, or if they have further questions. So these are things that you can actually let them know, so that they can recontact you. So there's also the fact that if it's a USC, what I'd usually say to the patient is that if you don't hear anything within the next 2 weeks, please let us know, because we're going to chase it. Then the examiner know that you know this is important, and you've got a plan in place and safety net as well. So there are things that you can do to show that you're doing this work, and it's not just USC referring, because there's also the human aspect. So you're discussing with a patient who may not have expected this. So I would not say USC on its own is a low challenge. There are various other factors that you need to consider.
Thank you so much.
That's great. The normal sequence will be the end, because then that's the thing that the patient will remember. But there's nothing that stops you from actually doing as you go along. So you could actually do that if that's your style and that's natural for you, and that works in the consultation. And you don't have to be rigid and follow like specific step as to when you need to do the safety net. You can actually do that as part of your discussion. If it works for you, then you can do it that way. But usually that's what most clinicians would do. We do it at the end, so that patient remember the last thing the doctor said. If this happened or that happened, then call back.
Okay, and about eyes questions, do you have any recommendation how to ask about them? Because sometimes I feel like it's difficult, especially when you said to the patient, what were you hoping from talking to me today? I don't know, I feel it's not mathematical.
So what I find is that each person would ask it a different way, and it needs to be something you'd actually ask them, and you're actually curious, and then will come natural to you. So sometimes people say things that doesn't sound natural, that sounds very odd. But if you're saying, patient, what were you hoping I could do to help you today? Like, that's something that would come natural to you. That's actually what I do. So that's what I would say to a patient. When I ask about the idea, I'd say, what were you thinking? So just see what they say. Like, but don't use the idea, because that's very formulaic. Just say, have you had any thoughts what this could be? Usually people have a thought as to what's going on. And if you actually ask it in context, so for example, that what you don't want to be doing is to do it as a checklist. So what did you think? What was your concern? What's your expectation? Like, that doesn't sound very good if you're doing as you're going through a checklist. But if it comes in the discussion and you just uncover it, then it comes naturally. So it's very in context. And then I think it's a good thing that you just, like you say, what were you hoping rather than expecting? Because some people use the word expecting, and sometimes it has a wrong connotation. If you're struggling with the RCA and you believe that you need help, then I'd recommend that you click the link down in the description below to book a free call to see whether we can work together on a one-on-one coaching program. If I think that I can help you, then we can get you on the coaching program. But if I can't help you, then at least you'll get some insights. I hope you find this video useful. Let me know down in the comment section if you have any questions or any suggestion. Take care, everybody. Bye-bye.